Conversations in Frailty, the podcast for Derbyshire clinicians.
So welcome to the next in my podcast series of Conversations in Frailty. I think we've got lots of regular listeners out there and it's lovely to have you back with us. But I'm also delighted if you're listening for the first time today. Do have a look on Spotify or on the DCHS YouTube channel to see all the past episodes. There's building up quite a library now, covering lots of really useful topics. So musculoskeletal disease is something that we hadn't particularly covered yet, so I was delighted to find a willing physiotherapist and had a sunny drive up to Bakewell to meet Nick Allen, who works in the north of the county and introduces himself on the podcast. Obviously there's a huge range of things we could have covered, so we decided to keep our focus really to degenerative diseases relevant in this cohort. We initially focused on degenerative disease in the form of osteoarthritis and had a really interesting chat with him about how we should be communicating about this condition with our patients. Now that we understand much more that it's not just mechanical wear on joints, but there's a more complex picture with a metabolic component. There's an inflammatory pathway in lots of our patients who have obesity and diabetes and gout and so on. And that's a useful area to be thinking about. And then we go on to consider how degenerative disease, which can lead to osteophytes and disc flattening and so on, can cause radiculopathy, which is the symptoms and signs caused when nerve roots are compressed, and also myelopathy, so the symptoms and signs of spinal cord compression. Finally, we touch on degeneration in the form of osteoporosis and a bit on vertebral fractures. And Nick explains for us the two-tier physio service in the county and when referral for joint injection is likely to be worthwhile just at the end. So lots to cover as usual. Enjoy. Great. So Nick, introduce yourselves for the listeners.
Hi, nice to be here. So I'm Nick Allen. I am a physiotherapist by background, and I have been in advanced practice musculoskeletal care for about 12 years. Okay. I'm just undertaking an ACP, actually, Masters in Manchester. But I've been in advanced practice for 12 years and in Derbyshire for about 6. And I've been a physio for a little bit longer than that as well, both privately and in the NHS through rotations. And I still do a little bit of education work outside of DCHS. And I have a busy home life with kids and dogs and
just been enjoying our chat about spaniels.
That's right. That's right, yeah, and the things they get up to, and yeah, essentially I'm a dad taxi for the boys and taking them around to cricket matches and bits and bobs in the summer, and trying to keep active as well as best I can at home.
All my, you're joining the club. All my podcast interviewees seem to be active and keeping themselves healthy.
Try to be.
Great. So yes, I've managed to rope you into talking to me today about MSK neck and back pain, particularly. We were thinking in frailty. So can you just sort of run through for the listeners a few of we were thinking, what prevalent conditions in this population do we want to kind of have a bit of a think about today?
Sure. So I mean, we see back pain in our cats and physio service a lot. It's prevalent throughout the ages, essentially, back pain. But there are certain conditions that kind of come along with age, generally degenerative, and that's the process of changes in the bone structures of the spine, as well as the ligamentous tissue and the muscular tissue that kind of just as it starts to get older, it starts to be less virile and strong, essentially, but you do get mechanical changes as well, and that leads to certain subsets of conditions that can, for some people, create problems both functionally and pain wise, and for some people it can be quite life-changing, but and I think one of the things that we talk a lot about is this we say degenerative and we say arthritis, and what does that mean? It can start very young. You know, we see patients in their 20s with arthritic changes in their back, and actually one of our spiels in MSK is that actually the normal processes, and they don't always that they are not always the driver behind back pain. So we've got to be careful when we scan people. We were talking about scanning earlier, that actually scanning can see structural changes in spines, but does it actually mean that that's the thing that's driving their pain or their problem?
People assume there's a correlation, and there isn't always. Yeah.
Not always. It's difficult to prove, you know. But there are certain things that are very much so, and that's the nuances of MSK and physio, where we can sort of correlate symptoms to then scan findings if we then go on to scan or image at points. But generally, you know, our spines change as we get older, you know, and for some people that's mechanical and metabolic, and sometimes that's this changes in their immune system, this immunosenescence, this changes of how their system works generally. And metabolic health in MSK is MSK health. We know that. In arthritic knees and arthritic spines, we know that it's not a wear and tear process.
Yes, and that term's gone out the window, hasn't
absolutely
it?
Absolutely. Yeah. So which actually is really important for us, because we can then try and spin the wheel there and say, actually, there are certain things that you can do beyond physio, so beyond rubs and massages and bits and bobs, which don't generally tend to work, to try and change that. And that includes better eating and better sleeping and more exercise and strength work. And strength really, for a lot of degenerative spinal problems, is movement. Motion is lotion, but strength around and spines is really helpful. And we know that from a mechanical point of view. We also know it from an inflammatory point of view. The seronegative arthritis that we get, we know that the strongest sort of the great evidence for change and stopping that ankylosing, if you've got sort of AS or inflammatory type back pain, is exercise and movement and strength that can actually physically change the pathways of spinal structures and pain mechanisms behind it.
Motion is lotion is not a phrase I'd heard before, but I like that.
Yeah.
And do you, I know wear and tear has gone out, and one other sort of phrase I've heard people use for this kind of degenerative spinal conditions is flare and repair. Is that something you talk to people about?
Absolutely, absolutely. And it's coming up, it sounds a little bit pedantic, but actually, you know, trying to get people away from the wear and tear is that because it almost feels like they don't want to move anymore because they're just going to wear their joints out. But we know that simply the metabolic processes of joints and synovial joints, and that includes your spine, if the changes that happen in the spinal joints and the ligament tissues around and XYZ is influenced greatly by your metabolic processes. And the more you load them, the more they kind of turn over and it changes how they respond. So, you know, you will always get the wearing of a joint because the cell turnover in a knee, for example, it'll turn over, and the repair of that, you know, is hopefully normal. But as we get older, if we don't use it a lot, or we're ill health, we're diabetic and we're overweight, and all the metabolic diseases that we can have, poor sleep, stress, you know, they influence how the joint can repair itself, which can lead to degenerative changes. So that's really important for us as physios to say, actually, that mechanism is a little bit different. We don't truly know why exercise works from a mechanical point of view, you know, because if it was wear and tear, why are we doing more exercises to help out? But actually, we know now that things like uric acid and A1C status are really good markers of joint health, and exercise can really influence those. Ergo, we can influence joint health. If that makes sense. And one of the difficult things with spines, especially as we get older, it's really quite hard to know what to do with them from a strength and exercise point of view, but they are one of the last things we think about when we're doing exercise, and we're very easily swayed to not move as much with our spines, and make noises as we bend down, and we were told to bend your knees when you move your back, and all those bits and bobs. Or you've been sitting at a desk, or you're sitting in a chair in the community at home and not able to move or get out, or you have very limited mobility. Your spine takes a brunt of it, not because there's extra loads from a postural point of view. Well, that may add. We know that posture is not really the big driver behind back pain. There's no such thing as bad posture. It's just your next posture is your best one. It's that case of moving into different ones often. but avoiding movements with backs is very easily done. And actually that can lead to sort of stiffness and weakness, which then leads to this downward slope into spinal pain. So
essentially, whatever a patient's level is, it's just getting them moving as much as they can, I guess, in that scenario.
Generally.
Yeah.
I think from an assessment point of view, you've got to make sure that it is just an arthritic process, or a degenerative process, or just a deconditioning issue, because there are spinal problems that need attention.
And I suppose so. We are saying what things are prevalent, and I think degenerative bone, degenerative disc disease is very prevalent. But what are those things then that you're thinking of in this population particularly we mustn't miss? What are the other things? So here I thought I'd put in just a brief reflection before Nick goes on to a helpful chat about ridiculous symptoms and radiculopathy. We're talking here very much about degenerative spinal disease in this cohort, and I think we just must keep in the back of our minds that obviously there can be a wider differential diagnosis for what's causing a sciatica. Cancer, we do mention, but also don't forget about infection, whether that's a discitis or an osteomyelitis in the vertebrae, or even potentially a spinal epidural abscess. Fever may well be a flag feature of those, but just bear infection in mind as well, obviously, as cancers.
So essentially, if there's any sort of radicular symptoms or radiculopathy, and the distinction between those two are quite important. So
just clarify for the listeners then, what are you meaning?
Yeah, so a radicular symptom is something that radiates from the spine down a limb, a leg, arm. If they become bilateral, then your ears prick up a little bit more, but a radiculopathy is frank neurological change. Okay. So the difference between the two, again, it sounds a bit sort of pedantic, but actually it can make a difference as to what your thoughts are going forward. For example, if somebody had back pain, lower back pain, mechanical with radiating unilateral leg pain.
Yeah, we see a lot of that. Yeah.
We see a lot of that.
Yeah.
With no radiculopathy, so no weakness, no sensory changes, then you'd be reassured that there was nothing sort of sinister going on.
Yeah.
And you generally wouldn't scan, or you certainly wouldn't scan early on. There'd be no concern for that. But if there was a frank weakness in a foot, or the leg felt incredibly heavy, or there was numbness, your threshold for scanning would be much lower.
Yeah. And urgency of scanning in that sort of scenario, what would push you to think actually this scan needs to be ASAP?
Weakness is
persistent weakness.
Yeah, persistent weakness. But they generally recover. There's these a long time ago we get really worried about drop foots, and they can be life changing, can be awful. But equally, the nerve that supplies the muscle for you drop foot generally is quite robust, so it can recover quite well, So do we scan for drop foots when we're in clinic? Yeah, generally we do, but sometimes we don't have to, and we can sort of sit on it a bit, and if it's recovering, then we can monitor.
I wonder, this is just a little aside really, but with the prevalent use of all these weight loss drugs, certainly that's a condition you sometimes get, isn't it, where somebody has dramatic weight loss and develops a drop foot, and I wonder if we're going to start seeing more of them because of that.
I think you're dead right, absolutely, and the problem with the inhibitor, the GLP stuff, is that it's mass loss, muscle mass loss as well as fat loss, and as they come off it, they've lost the muscle mass, but then they gain the fat tissue again, and then we see it a lot now in the physio land that people they become sarcopenic very early, and their condition is fairly poor, and I think that'll just continue.
However, that's probably not a frailty thing really, but it's an interesting aside.
Yeah.
So yes, radiculopathies. what are you going to be, if we're picking up on those persistent numbness, weakness, what are the underlying conditions that then is in the back of your mind in this frail population?
Yeah. So again, it's about where the radiculopathy is. If it's bilateral, upper and lower. So simply, if there's a unilateral lower limb radiculopathy on one side that hasn't improved over time, or is quite frank, sensory or motor wise, we'd scan lower back generally, lumbar spine MR, to make sure there isn't any compression of the nerve root that we guess is causing the problem. We know that if there's a drop foot, it's a lower level lumbar problem, and if it's a hip problem, it's probably a little bit higher. So we scan to make sure there isn't any compression, and we scan for surgical injection target. That's essentially what we do to keep it really clinical. Is there a target for us to do something about going forward? That's very cold. A lot of people come in with back problems that have been going on for a long time with ridiculous symptoms, and we can reassure them. Sometimes we can reassure them with a scan to say there is nothing really going on that's concerning. But when it becomes bilateral, it starts to be a bit more of a red flag, especially in the older population. So you're into the realms of stenosis, and you're into the realms of cauda equina, syndrome. And cauda equina is more prevalent in the older than in the younger population, and it's usually degenerative sort of central canal stenosis. Right. So that tightening of the central canal in the lumbar spine that creates the tightness around the cauda equina. In the younger population, it's more of a mechanical discogenic issue, where that space gets filled up with a disc. In the older population, it's the degenerative changes, or the spondylolisthesis, so the anterior or spondylolisthesis, where the vertebral bodies move a little bit, moving sort of
in opposite directions, as
Absolutely.
it were.
Which creates sort of canal stenosis. And symptoms there are classic cauda equina, but don't always have to be.
I was going to say the problem in the elderly is we have a higher prevalence of incontinence issues already, so then that subtle questioning that you would normally do around changes in sensation and continence are potentially more challenging, I guess, aren't they?
Greatly so, and drugs as well. So certain drugs create urinary problems, X, Y, Z. So and the thing is, with cauda equina, it can be quite sort of nocivic. It can create sort of concern for people, and really, if you're sending people into a hospital because of that, it's a big ask, isn't it? And we do it a lot. We say, we get very rigid with it, and we have to say, well, you've got this, and this, and this. But like you say, there are nuances of around, and MRI scans are not nice places to go into, and they're difficult for the older population a lot of the time, getting there, actually having it done, and they're not a nice place to be if you've got back pain, because you've got to be still for quite a long time. But so ridiculous symptoms in both legs are certainly a bit of a flag, but you've got to pay attention, and lots of clinical reasoning around that. But then you get sort of upper limb symptoms as well. If you're getting bilateral upper and lower limb symptoms, you're in the realms then of cord compression rather than peripheral compression, which is more the sort of degenerative cervical myelopathy territory, that kind of thing. Or is it not an MSK problem? Are we looking at something more central and more neurological driven than that? So essentially, if folk are getting new bilateral upper limb and lower limb sort of neuropathies, tingling in their hands and feet, weaknesses, dexterity issues, gripping problems, trouble with their gait, beyond what they are their baseline, it's generally described as unsteadiness or drunkenness is the big one in cord compression. Then we would scan from top to bottom. And make sure that they
brain cord.
Well, we can't do brain here. But we certainly do a cord initially. And if there was nothing on cord, then we tend to go either back to the GP or to neurology to say something going centrally. But we'll make sure that we haven't got anything mechanical that is compressing the cord and creating this myelomalacia, which is the compression and bruising of the central cord.
And there you're thinking the degenerative stuff, sometimes disc.
Absolutely. And that can cause also weird and wacky problems. And that can cause urinary problems as well, incontinent issues and X, Y, Z.
And what about spine? I suppose the other thing we need to be thinking about spinal cord compression is bony mets. So
Absolutely.
Particularly again in the older age group, higher chance that we've got that going on.
Yeah. Especially the history of cancer. You know, males with prostate is really common. Females with breast cancer. So certainly if they've got a history of that and then they've started to develop back pain and peripheral symptoms with central sort of long track signs, we need to be really careful about getting them in to see somebody very quickly.
And just for the listeners, long track signs, what are you thinking when you say that?
Balance
the balance
essentially.
Stuff.
The sort of cord compression where people have sort of odd gaits, sort of high stepping generally, or very broad base. Difficult in the elderly population because they tend to have that anyway.
Yes.
But if there's anything rapidly changed there, coupled with bilateral peripheral symptoms, tingling, pins and needles, and pain. The problem sometimes with cervical myelopathy is that a lot of the time they don't have neck pain. So they just get neurological symptoms.
And that catches us out because we assume that they must have to have neck pain. Yeah. Okay.
What taking a little step back, from an MSK point of view, we've got to be really careful that because around about having a pre-diagnosed condition and coming in, because we're at the end of a line with a lot of this stuff, and people have lots of past medical history. A very difficult case that that sticks in my mind was a lady who came who in July she had been walking the coast to coast. And she was probably 70, she was really quite fit and active. And by December, she was in a wheelchair. And she'd come into the department because she wanted, out of the blue, she tried to self-refer into the physio tier 1 department because she said her gait was a little bit difficult. She was in a wheelchair for most of the time. She could walk and she was getting swollen legs. It's a long story, but essentially she had swollen legs out of the blue, and then infections, and then dressed by the community district nurses. She'd been to urology, so she had idiopathic sort of bladder retention and was taught to self-catheterise and bits and bobs. And it turns out she had cord equinus, and then she was backing up and getting these swollen legs because of that.
Gosh.
So from our point of view, we've got to be really careful that we're not just relying on the diagnosis that has been previously. And it's the same with myelopathies. We see a lot of them just get put down to vertigo or anxiety a lot of the time, because it can create a lot of anxiety.
That's what
in the elderly. And I suppose it's our bias. We could say, well, what is it an MSK called?
Yes. I guess the thing that jumps out at me there that we need to listen for is the functional change, isn't it? Because in that story, when you stand back, it was that dramatic decline in her functioning. Yeah. And
it's interesting because as an ACP or as a physio, you say, well, this lady has been to urologists, she's seen a consultant twice, 3 times. They've been to GPs, they've been to the nurse, they've had all these things prior. It must be this. It's about keeping your wits about yourself.
It is, isn't it? And just having that fresh set of eyes, and so. And remembering to say, actually, what were you doing a few months back? What was your baseline then? And because we jump in, don't we, and see somebody where they are now, and it's getting that change.
Absolutely. Yeah. And that's difficult, isn't it? In the frail person who's been at home for a very long time, and their function is very poor, and then all of a sudden they say, I've got back pain now. Most of the time it's very likely going to be mechanical, spondylitic, spondylitis, arthritis. It's the subtle changes of any other peripheral symptoms generally that we should be concerned about. Yeah. Especially if they're bilateral, especially if they're progressing.
Yeah, great. And the other condition we haven't touched on that I just said we maybe briefly mentioned today, of course, is osteoporosis, because insufficiency fractures are certainly something we see. And there is going to be an upcoming podcast on osteoporosis. So I said, let's not go into that in too much depth. But I suppose one question I had around that was just imaging. If we see a person who's known osteoporosis, presents with, quite sudden new back pain, and we're suspecting a vertebral fracture, what should we be... X-ray.
Thoracic spine X-ray. That would be the first protocol. When we would MR is when we had in neurology. Are there any retropulsive problems with the fracture that's causing compression of the cord or the peripheral system? And then we would MR essentially.
But if it's essentially pain, it's a case of getting an X-ray done. Yeah. And I found an interesting study actually when I was doing a little bit of reading around this that said, I think we're so aware of the mortality risk after a hip fracture. Yeah. But there was a study in Iceland recently where they followed up people who'd had vertebral fractures for 5 years, and said that actually that was the type of fracture that had the worst function and the greatest health burden compared to fractures at other sites. So I think it is one that we need to, be very aware of in this population, isn't it?
I think so. I think from an MSK point of view, we've known that for a while, and it gets missed. People have sort of thoracic back pain out of the blue, non-traumatic, sort of 60 and above, and the first thing you think is it a wedge fracture? Is it interspecialty fracture? And the problem is sometimes that they get missed for so long that from a treatment point of view, their options get so limited, and then it's kind of pain management and conservative measures, which is fine, but there are things surgically that can be offered for sort of vertebroplasties and that kind of thing.
Yeah.
But the evidence around that is that the earlier the better with it, and if it's been going on for a year, it's
you've kind of missed the moment.
You've missed the moment. Yeah.
So that's the kind of logic in doing the X-ray, isn't it? That it could change the outcome in terms of what management they can offer.
Absolutely, absolutely.
Yeah.
And they don't generally tend to progress, but sometimes they do, and then sometimes you get sort of neurological symptoms, or that there has been sort of cord contact at the time originally of the acute fracture. It just was never picked up on because that's what happens a lot of the time, and then you get this change over time with the cord, and you can get problems beyond that.
Fine.
So.
Right, well, the last thing I wanted to just touch on with you was just a reminder for people about how the MSK services kind of work across the county, because just in terms of thinking, if a patient is able to get up to a clinic, potentially injection, that sort of thing, just run us through how it's structured.
Sure. So Derbyshire generally has two levels of physio. Tier 1, which is the physio that you would think of physio, and that's rehab, but they're self-referral as well, so they generally see undifferentiated patients with a triage service beforehand, and there's self-referral for there, or there's referral via primary care. So the team will do a very good assessment essentially, and then they can issue some rehab and classes and guide people into where they need to be from a triage point of view sometimes, and that can be up into us, if there's no medical issues, because a lot of people go from tier 1 from a self-referral into GP land because it's like, this is not MSK, thanks very much, and that happens a lot with the elderly bloke. You get a lot of sort of weird and wacky things that actually need a tick off first with the GP. Or they come into us. And essentially, we're physios that have a little bit more of a multi-system training, and we can image. We can give peripheral injections. We can't give spinal injections. Okay. So spinal injections, essentially, we will work up for, and if there's neurology that may respond to injection, then we'll scan, and then refer on.
You can escalate it up.
They're generally done under a C-arm, so X-ray guided for most things. But injections are poorly funded generally. They can be helpful. They tend to use them for not pain therapy, but for pre-surgical planning. So if there's an injection that works, then they're a good surgical target if there's a target there in the first place. But they used to be very prevalent injections, and they've very much come down. Yes. Because they are not very good generally, especially cervical injections. They are very, very risky. Right.
So that shouldn't, when we're thinking about necks and backs, injections shouldn't be high on our
list. Not for
list
actual pain.
No.
It just won't work. Generally, surgery and injections are for peripheral symptoms, and that's radiating pain or sometimes sort of mild neurology.
Okay, great. Lovely. Oh, it's been really helpful. I shall enjoy listening back to this and just sort of picking out some of those areas, particularly around the sort of types of neurology and when we need to worry. So
sure, well, it's been a pleasure. Thanks so
much for your time.
Yeah, good.
Well, I expect you gathered that I really enjoyed that conversation with Nick, and I will just add in that I think he gets the award so far for the best coffee produced for a podcast recording. Absolutely delicious. I think he said it was from Vietnam. Anyway, thank you, Nick, for that. What were my sort of learning points at the end of this one? Well, firstly, I think just the key reflection that if we better understand the metabolic activity underlying osteoarthritis and the possibility of ongoing joint repair, that can better underpin our communication with our patients and try to get away completely from the idea that activity will wear their joints out. In terms of the sciatica we were discussing in this patient cohort, it's worth remembering that degenerative disease is the likely cause, and this is often a chronic issue, but it can take an acute dip, and so watching for frank radiculopathy and especially bilateral symptoms are really key red flags. And like so many conditions, cauda equina doesn't always present like the textbook descriptions in our elderly population. And my final learning point was really just the idea that cervical myelopathy often presents with no neck pain. So it is something we should be thinking about when we have patients with tingling hands and feet, new problems with hand dexterity, poor balance and unusual gaits. All things that we see in this cohort of patients. And finally, listen out for my podcast on osteoporosis, where we'll go into that topic in lots more depth, and that's coming soon. And as ever, my normal disclaimer just to say that obviously this is a conversation with one expert in the field, so when you're considering a clinical case, use your own personal judgment, local and national guidelines to help make your decision.
Conversations in Frailty. Thanks for listening.